We'll start off with Dr. Arlene Chapman, who will discuss classification of Alports using genetic testing.
Good afternoon. I'm going to be talking to you today about Alport syndrome and the approach to a genetic diagnosis for these disorders. I'm going to first start with a case of a patient who's a 30-year-old woman who's followed by a general nephrologist, and she's had persistent proteinuria of unknown etiology. She has a positive family history for kidney disorders. She has 2 children, a 2-year-old son who had hematuria and was referred to a pediatric nephrologist. Prior to kidney biopsy, renal genetics panel were ordered for the son. The test results gave a positive result for Alport syndrome, and the mom was subsequently tested, who also was found to have the same mutation as her son. So the impact of this is that we can streamline diagnostic workups using the molecular diagnosis. In this particular situation, a biopsy was avoided in the mom and a diagnosis was obtained. They can also obtain appropriate referrals specific to Alport's disease, including evaluations for both hearing and vision. And an early diagnosis for the son can be obtained for preventative nephrologic care. It also allows the family to make planning choices, for example, with pre-implantation genetics, to avoid passing on a mutation for the Alport disease in subsequent pregnancies. So it's really timely that we can now integrate genetics into nephrologic care. It helps for classification and reclassification of clinical diagnoses. It allows us to broaden the spectrum of disorders from a phenotypic or pathologic standpoint. And it allows for childhood conditions to be diagnosed prior to entry into adulthood. And ultimately, this will feed upon itself in terms of discovery and allow for new gene discoveries. So Alport syndrome's diagnosis is a glomerulopathy, which is associated with sensory neural hearing loss and ocular anomalies such as conus lenticus. It is caused by a number of mutations in collagen type 4, which are found in the ear, the eye, and the kidney. There's col4 alpha 3, col4 alpha 4, which are recessive and dominant traits respectively, and there's col4 alpha 5. 65% have been found to be X-linked. After autosomal dominant polycystic kidney disease, Alport syndrome is the second most common genetic cause of kidney disease, and it occurs in 1 in 50,000 births. And it has been shown that in random genetic testing is responsible for 30% of positive genetic test results in a paper recently published by Groupman et al. And here you can see the breakdown of the genetic findings from these individuals. And of the col4 alpha 3, 4, and 5 mutations, 62% had been misdiagnosed or had not been diagnosed as having Alport syndrome or thin basement membrane disease. So certainly a big change in terms of genetic diagnoses, which also leads to differences in management for these patients. So I'd like to talk a little bit further about classification of Alport syndrome. There's a publication here for your review in Kidney Medicine from 2020 that helps identify many of the issues that I'm going to highlight. And classification of Alport syndrome is really defined as progressive loss of kidney function with distinctive ultrastructural changes in the glomerular basement membrane. This is where the collagen alpha 4 is found. There's sensory neural hearing loss, and there are variable ocular abnormalities. Alport syndrome is X-linked in approximately 65%. It is autosomal recessive in 15%. And autosomal dominant cases have been found in approximately 20%. Based on the current classification, Alport syndrome accounts for 3% of chronic kidney disease in children and 0.2% of adults with end-stage kidney disease. And as I said previously, it is the second most common monogenic cause of chronic kidney disease after autosomal dominant polycystic kidney disease. So as a reclassification scheme, the Alport syndrome classification working group recently proposed a reclassification scheme of glomerular disorders of the type 4 collagen alpha 3, 4, 5 molecule. Based on clinical and molecular genetic criteria, instead of relying solely on histological and clinical traits that can be both gender and age dependent or potentially modifiable by remote genetic variants or exposures. This would allow for a reclassification of thin basement membrane and some cases of FSGS to an Alport syndrome and define indeterminate genetically by putting them into 3 distinct diseases of type 4 collagen, either X-linked, autosomal, or digenic. And so this would help to identify patients at risk for progressive loss of kidney function. It would promote proactive surveillance, and it would allow for early initiation of nephroprotective therapy. So the new classification is based on clinical and molecular criteria instead of biopsy and variable clinical traits. So with greater frequency of genetic testing, our understanding of the risks for progression can improve as more individuals with autosomal dominant Alport are identified and are not either misdiagnosed or given a non-specific diagnosis of chronic kidney disease. And you can see in this table there's a proposed new classification scheme that categorizes genetic diseases of collagen 4 alpha 3, 4 alpha 4, and 4 alpha 5 into 3 types of Alport syndrome, either X-linked, autosomal, or digenic. And here are the X-linked collagen 4 alpha 5. In males, they can be hemizygous and affected, and in females can be heterozygous, usually less severely affected clinically. We can have the autosomal collagen 4 alpha 3 or collagen 4 alpha 4, either as a homozygous or compound heterozygous, which would be in the recessive Mendelian pattern, or as a pure heterozygous form, which would be the dominant form. Our digenic compounds would be collagen 4 alpha 3, 4 alpha 4, and 4 alpha 5, and this would be variable with regard to the type of inheritance pattern that would be found in this situation. So for X-linked Alport syndrome, under the reclassification scheme, women with X-linked inheritance previously seen only as carriers would be diagnosed with Alport syndrome and be considered to have an appreciable risk for disease progression. The dominant disorder would be found in those with the autosomal dominant inheritance pattern. Their estimated risk for end-stage kidney disease is more than 20% for those risk factors for progression that include proteinuria, evidence of FSGS on biopsy, glomerular basement membrane thickening and lamellation, sensory neural hearing loss, and evidence of progression in patient or family genetic modifiers, and in less than 1% when these risk factors are not present. In digenic forms, digenic inheritance affecting the 4 alpha 3, 4 alpha 4, and 4 alpha 5 genes will have a variable estimated risk for end-stage kidney disease depending on the affected genetic state. So up to 100% for collagen 4 alpha 3 and 4 alpha 4 mutation in trans, simulating autosomal recessive transmission, up to 20% for collagen 4 alpha 3 and 4 alpha 4 in cis, or the same chromosome, stimulating autosomal dominant transmission, and up to 100% of affected men for mutations in collagen 4 alpha 5 and either collagen 4 alpha 3 or 4 alpha 4, in which the inheritance pattern does not simulate any Mendelian transmission. With regard to recessive Alport syndrome, there would be no change, both sexes experiencing 100% risk for progression to end-stage kidney disease. Recent expert consensus guidelines recommend genetic testing for confirmation of Alport syndrome diagnosis. Genetic testing is more sensitive and specific than a kidney biopsy, and it's recommended as the gold standard. When Alport syndrome is suspected, collagen 4 alpha 3, 4 alpha 4, and 4 alpha 5, next generation sequencing can identify up to 95% of pathogenic collagen 4 alpha variants. Recent gene sequencing studies consistently demonstrate that variants in collagen 4 alpha 3, collagen 4 alpha 4, and collagen 4 alpha 5 commonly result in sporadic and familial adult FSGS, which should be identified as Alport syndrome based on the reclassification proposal. And this would have a direct impact on therapeutic approaches for these types of patients. And with that, I'll complete my presentation. Thank you.